a cardiologist. My topic is about epidemiology in atrial fibrillation, specifically in Africa. So, of course, definitely when we're discussing epidemiology, largely when it comes to Africa, the biggest excuse is that there's paucity of information, especially in terms of atrial fibrillation, causes, epidemiology, and patterns. However, we shall try to look into the actual differences that we see in comparison to Western data. So generally, we know, of course, it's the most sustained arrhythmia, causes approximately a third of all hospitalizations, and it's a progressive disease. Uh, uh, the reason why data is a bit scarce is mostly because it's not collected, or there's limited inertia for research, especially in Africa. And despite medication, we note that the disease is quite progressive, so it means it has a nature of being a bit frustrating to the clinician and also for the patient. And as we can see that it can progress from, a paroxysmal, it can be persistent, and all the way to permanent. And sometimes maintenance of normal sinus rhythm is quite difficult. And we see the pathogenesis, we see that even after multiple cardioversions, especially if you've got persistent AFib, it's going to be quite difficult, especially even within 1 year. And as we see, within 3 years, patients with persistent AF will progress. We see that initially, an initial episode of AF, if you get just one event, just as Dr. Felix had highlighted earlier, your chances of developing a subsequent event are quite high, sooner or later. So it's a matter of waiting when it comes to atrial fibrillation. And we see the predictors for atrial fibrillation. Generally, most comorbidities of cardiovascular disease, heart failure, chronic pulmonary disease, and hypertension are the major predictors when it comes to atrial fibrillation. And we see when we match with patients without the same conditions, the incidences and predictors and incidences and prevalences are quite low compared to patients with all these comorbidities, as well as progression of disease. So it's much worse. So from a global perspective, before we come to a bit of information in Africa, we see that generally it's a big problem. 33 million people, globally. Even when we adjust, there's slight differences, men and women. We think it's slightly more in men, though some literature disagrees. And generally, the prevalence is about 0.5 to 2%. Slightly much higher because we see that in the era of smart devices and watches, they are picking up signals suggestive of atrial fibrillation that are outside the current statistics that we have. Therefore, and we know, just as you see the electrophysiologists, the numbers are growing, but slowly. It's going to be difficult to catch up with the 5 million people developing atrial fibrillation every year globally. So we are very, 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 very positive that such associations are going to be useful in tackling the challenges with atrial fibrillation. So why do we think that with increasing the time is going on, as we see the increase is 5 million people, why is this number coming up? I think the easiest excuse is increased longevity. We think the longer we live, the closer we come to getting an incident event of atrial fibrillation. And we look at the Western information, especially US and UK, approximately 2.7, 6.1 million patients. And it's also expected to rise, both in the US and in Europe. The reason for this, I'm not quite sure. Maybe smart devices, because when it comes to them, I think patient to doctor ratio is much higher, and the epidemiology is much better. And in Africa, overall, what do we see? We see that generally it's slightly higher. Why? The lower limit, for example, Kenya could say that 0.7%, and we're seeing some higher limits, for example, in Ivory Coast at 5.5%. when we looked at the general information, we are coming slightly less at around 5.0%, but generally we see that it's in some literature slightly higher, in some literature slightly lower. So, and in Africa, of course, our general population in Africa is slightly younger compared, of course, to the more developed nations. And that's one of the reasons that they think that atrial fibrillation may be having different causes compared to the rest of the world. And significantly, recently, I think work from Bongani, the distribution of cardiovascular diseases or causes of heart failure in Africa, we see that idiopathic, in quotes, idiopathic dilated cardiomyopathy, majorly the reason for heart failure. And when we see the same population, it's the same population we're having higher atrial fibrillation. It's easy to think that rheumatic heart disease should be the reason, but as we see the distribution of hypertension globally, especially Africa coming back much higher, therefore it means that we shall have a lot of atrial fibrillation. So therefore, as you can see, hypertension, association, cause and effect, we can observe 50 up to 87%. Rheumatic heart disease will share with dilated cardiomyopathy around the same. And of course, atrial fibrillation is a disease of comorbidities. Diabetes takes a key position, as we can see. Independent studies, THESAS HF has shown us approximately 18% prevalence of atrial fibrillation. Nigeria is found about 20%. And when we observe patients with ischemic stroke, we find approximately 4.2% could have atrial fibrillation in the background. It's difficult, especially as we walk up, sometimes we catch nothing. So furthermore, for example, in Nigeria, still dilated cardiomyopathy and hypertension are still the key conditions that are associated with atrial fibrillation. And the burden of atrial fibrillation. So the less the experience, or the less burden of atrial fibrillation you have, the lesser the events, as you can see, paroxysmal to device detected, and permanent if linearly associated with events of stroke. And once you have atrial fibrillation, for whatever reason, that is an independent risk of death. As you can see, 5 times risk for stroke, increased risk for dementia, increased risk for heart failure, increased risk for myocardial infarction. So the same population, you would think maybe anticoagulation could help, but that's not the case. So once you have atrial fibrillation, you're in trouble. So our efforts should be increased. And mortality is the same situation. So what happens? When someone has atrial fibrillation, we are worried about stroke. But when time for when we assess the cause of death, usually it's sudden cardiac death, heart failure, myocardial infarction. So it means that maybe the drivers for the cause of death are slightly different from atrial fibrillation itself. So therefore, the comorbidities, for example, if they are worse, it means your risk of death is much higher. So as we shall see in a summary ahead, as we focus on the management of atrial fibrillation, rhythm, and rate control, we should remember to put much more effort in the comorbidities of this patient. Some nice studies in Africa. Interstroke, we see that in Africa, when we see this forest plot, the same distribution, around the world, Western Europe, South America, and China, the risk for stroke, almost cardiac diseases are usually associated with atrial fibrillation, and indeed, same findings with actually getting an ischemic stroke. So not much difference. The only difference is usually due to the distribution of actual cardiomyopathies in Africa and the prevalence of hypertension. So it's easy to find a structural heart disease in patients with atrial fibrillation, and it's been a challenging question to wonder what's the chicken and what's the egg, but we know it's a complex continuum. So when you have atrial fibrillation, look for another disease, look for structural abnormality, and occasionally you find nothing, but all efforts should be put in identifying, the causes of atrial fibrillation. So in addition, the risks, if someone has hypertension, just know that sooner or later, as you follow up this patient, they will get atrial fibrillation. If you have diabetes, sooner or later, you will get atrial fibrillation. And unfortunately, for some things we can't modify for age, the longer you're on earth, the closer you're coming to atrial fibrillation. It's been the same. So the distribution, for example, rheumatic heart disease in Africa, it should, bring the caution of atrial fibrillation much closer, especially when the patient complains of palpitations. So we see that especially in younger population, because they have lesser associated comorbidities, we think that's the reason why the prevalence is much lower, except for the case of rheumatic heart disease. So what is modifiable, what's non-modifiable? Age, for obvious reasons, but with increasing age, increasing prevalence of hypertension, increasing age, increasing chances for incidence of getting MI. But we see once you're above 65, it's much higher compared to before 65. Some literature disagrees that it's more in men, but generally we think the numbers are quite equal. One excuse is that the longevity of men is quite lower compared to women, and that's the reason why if the numbers for atrial fibrillation are becoming quite similar for age and men, for gender. So race is being observed more in the developed nations, but I think these numbers, due to the different distribution of diseases, especially hypertension, it could catch up. Yeah, and then remember, genetics play a role, but it is difficult to discuss genetics with atrial fibrillation. Why? But we observed in offsprings of parents with atrial fibrillation, there are higher, much higher incidences of atrial fibrillation and prevalences. And obviously, when it comes to the modifiable, hypertension is key. And Africa, as we discuss atrial fibrillation today in the Heart Rhythm Association, we know that Africa is leading in the prevalence of hypertension globally. So means that it's going to hit us quite hard, so we better work very hard. So for obvious reasons, heart failure, LA dilation, stretch, fibrosis, you're going to develop atrial fibrillation. The chances are much, much higher. And it's easy to assume that the patient with reduced ejection fraction has the bigger hemodynamic load on the heart, but as we observe, it's almost equivalent with preserved ejection fraction. So don't get comfortable, do the BNP, because that's the only marker now we are getting comfortable with identifying preserved ejection fractions, because we are barely seeing anything suggestive of the same disease. So someone has dyspnea, suggestive of preserved ejection fraction, AFib is nearby, it's coming for this patient. And similar mortality with reduced ejection fraction. So for obvious reasons, valvular heart disease. But what's the trick with valvular heart disease? Mostly the definition. Rheumatic more than mild stenosis as opposed to mitral regurgitation. That's where the gymnastics of anticoagulation are coming in. But we observe that outside this, even non-rheumatic valvular heart disease will have slightly higher incidences of atrial fibrillation compared to the rest of the world. We see that it's much more in mitral disease as opposed to aortic disease. We'd assume it's mitral disease is closer to LA, fibrosis, dilation, and hemodynamic load. And just like everyone has observed, the larger the LA, for obvious reasons, the higher the chances of developing atrial fibrillation. This has been explained already. It's mostly a mitral valve disease, but we see even aortic regurgitation will result into volume overload in the LV, which will translate to volume overload in the LA. So we are observing, due to the risk of due to the coronary artery disease, that means it's much higher in the Western world. That's why they see the distribution is slightly different. And for congenital heart disease, The more complex the lesion, the higher the chances of developing atrial fibrillation. And ASDs that make it to patients above 40 years, that means the chances of developing atrial fibrillation will be much higher. Obstructive sleep apnea. We rarely focus on this, but remember, if a patient has atrial fibrillation, look for OSA. And if you don't control OSA, you're going to progress much worse. And for obesity, unfortunately, moderate exercise, for obesity, it's also a linear relationship for obvious reasons. But for just a moment, diabetes I already discussed, and hyperthyroidism, a keynote to take home is sometimes the yield of thyroid function tests is very, very low, but always do it. Why? Because when you identify it, it's a reversible cause. Pulmonary embolism, some studies suggest that maybe you could get RA clots. Very difficult to think that that's where the PE came from, but remember, we don't know what's causing the other, but PE will cause RA dilation, therefore increased risk. Same is for CKD. Why? Hypertension is in the same mix, and in addition, a lot of inflammatory markers are happening. It comes to exercises, remember, for men, don't do it very vigorously. Why? Apparently, it increases risk of AFib. Surprising. That's not the same for women, but for moderate intensity exercises, it's quite beneficial for you. We are enjoying our stay in Rwanda. So last night we had a bit of wine, but the moment it's a lot. Some of us, if we had a lot this morning, we could get palpitations, so some caution. Advise your patients, to tone it down. Smoking, we don't know how it's associated, but it does cause the same. It's difficult to stop patients from taking caffeine, but we think when someone comes with palpitations, it's a good excuse. Then lastly, remember, it could have also non-clinical scenarios, postoperative, coronary artery disease, bypasses, and corrective surgery. In summary, the differences from Africa as opposed to the Western world is due to the distribution of disease. Pay attention to the comorbidities. You don't manage them, it will be a very frustrating disease. Control is not successful, especially if you don't focus on the comorbidities, and generally it's a progressive disease. Our efforts is mostly to slow it down. Thank you.
Thank you very much, Dr. Elijah. Let's move to our second presentation. How well is anticoagulation managed in Africa? This will be presented by my colleague, Dr. Esubalu Asfa, who works at the King Faisal Hospital, is the head of the Adult Cardiology Fellowship Program.